Happy New Year, everyone. And yeah, I hope that this new year brings a lot of good luck to you. So, first talk of the year, I'm going to talk about overview of Charcot joint. I think Charcot joint by itself is a very common, problem that I, as a foot and ankle surgeon, see. And unfortunately, the awareness about Charcots is very limited even in the orthopedic surgeons. So I see a lot of patients being diagnosed as Charcots, but still not being managed properly, which eventually leads to a lot of complications and disruption of the bony architecture. So by this talk, I think my main idea is to just give you an insight about what exactly is a Charcot arthropathy. How do you suspect that? What are the various stages and etc. Um, and then give you a lot of examples of my patients that I have operated upon and tell you that, explain to you that it is not really an easy nut to crack and you need to be prepared for the worst and counsel the patient adequately whenever you are managing a patient with Charcot's arthropathy. The incidence of complication is a lot, but the basic idea of dealing with the Charcots is that you are avoiding amputation of the patient. So your main aim is that amputation is avoided. Apart from that, a foot which is braceable, which is which is plantigrade and which is painless and stable. So this is what you have to achieve. Apart from that, if it is a bad looking X-rays, a little bit deformity, I think we all accept that. We have to keep our expectations quite low in Charcot's joint. So starting off with the talk now. Okay, it just starts with this patient which came to me quite some time back. Is a 52-year-old male patient referred to me from a physiotherapist as a case of fracture. The patient came walking. He did not have any injury, but he was playing badminton and then he started developing some pain and swelling. Um, and this was the X-ray which with which the patient came to me. And as you can see that there is an evidence of a displaced navicular fracture, or I can say navicular fracture dislocation. But the patient had reasonably, was reasonably pain-free. Uh, just, when you ask them, he said, yeah, I have mild pain. On asking history, came to know that patient had a known diabetes for many years. So looking at this, you know, we know that we are dealing with something called a Charcot's arthropathy. I was the first one who saw the patient as an orthopedic surgeon. So I saw the patient and I advised that this is what it is. We have to, and this looks, if you look at this X-ray, it's a very reasonably aligned uh, AP and lateral view. And if the bone organizes in this, I'm very happy, and I think that's what it is. So I explained to the patient that this is a Charcot joint; it has a tendency to progress. I advised him for a total contact casting. He was not keen, so finally I gave him a boot, which is nothing but an air cast boot, which is nowhere close to what is the ideal management. And he had a lot of questions. He finally purchased a short boot against my advice. And then he removed himself after 2 weeks as he did not have any pain. And that is a problem that they are neuropathic, they don't have a lot of pain. And they are saying, कि यार ये डॉक्टर तो पागल है बकवास कर रहा है पता नहीं क्या बोल रहा है. And finally came back to me after 2 months with this X-ray. And so, as you can see, that it has gone into a full-blown Charcot's with the dislocation at the talonavicular joint and calcaneal cuboid, and eventually rocker bottom foot deformity, which we know is really unstable and it requires some form of surgical intervention. I mean, this is the patient that I eventually did not manage because I explained to him. He was still not very convinced, and he finally went to another doctor. So I don't know what happened with him eventually. But again, if you see this X-ray, the main idea is you need to understand that the patient currently is in a stage of fragmentation. So if there is no ulceration, you probably have to think about waiting for some time and giving him a total contact cast if there is no pressure ulceration, and keeping him non-weight bearing. Don't directly jump into them and do a surgery, which probably this patient eventually underwent from a different doctor, because I refused to operate on him at that point of time. I said I'm going to go give a TCC even at this point of time. So, what exactly is the Charcot's arthropathy? It's a relatively painless, progressive, and a degenerative arthropathy of single or multiple joints, and it is caused by an underlying neurological deficit. So, it is relatively painless. The patient may still have a little bit amount of pain, but it would be disproportionate to the amount of distraction that you're seeing. It tends to be progressive. It can involve single, or in actually most of the time it's a foot, so it can involve multiple joints. And the most important is there should be an underlying neurological deficit which predisposes to it. Um, so who actually found Charcot's? From where this name came was from a French neurologist named as Jean-Martin Charcot. He described the severe arthritis in patients with Taves dorsalis, which is syphilis, in the year 1868. And so after many years, almost after 70 years, uh, it was diagnosed to be associated with diabetes in by someone called as Jordan. So joint destruction, which are due to factors which is unrelated to the joint itself, it is painless and it is associated with secondary ulcerations. So common causes of Charcot's arthropathy, I think in my experience, the most common disease that we see is diabetes. I think it is one of the most common leading causes worldwide of Charcot's arthropathy, and so is in India as well. Second is Hansen's disease or leprosy, then Taves dorsalis or syphilis, in which it was actually found, and any condition which involves neurological involvement of the foot or neurological deficit is associated. It can be a spinal cord tumor, Charcot's-Marie, pernicious anemia, alcoholism, cerebral palsy, polio, and syringomyelia, anything. And there's another entity called as congenital insensitivity to pain, which can also be associated with this. I think another reasonably common one is it can be seen in alcoholics as well. So diabetes, as I said, is the most common cause worldwide, which is leading to Charcot's arthropathy. Now we're talking about the Indian scenario. So as